Okay, we're going to go ahead and get started. First and foremost, welcome. My name is Robert Sellers. I'm Vice Provost for Equity and Inclusion and Chief Diversity Officer. And it's my great pleasure and honor to welcome you today to the 2016-2017 Nancy Cantor Distinguished Lecture on Intellectual Diversity. The lectureship, this particular lectureship, honors Nancy Cantor, who is a former professor in psychology, dean of Rackham Graduate School, as well as U of M provost. Nancy Cantor, throughout her career, has lived a life committed to promoting diversity, equity, and inclusion throughout higher education. While at University of Michigan, Nancy was a key architect in the university's decision to defend the use of affirmative action to the Supreme Court to achieve a more diverse student body. She has also been an outspoken advocate for eliminating barriers to higher education and expanding the life opportunities and life chances for all in the society. Nancy continues to do this work as the current chancellor of Rutgers University at Newark. In keeping in mind the original goals of this lectureship, I think of no better person than our speaker today, Dr. Thomas A. LaVeist. Tom is the chairman of the Department of Health Policy and Management at the George Washington University Millikan Institute School of Public Health. He joined GW after 25 years on the faculty of the Johns Hopkins Bloomberg School of Public Health, where he was the William C. and Nancy F. Richardson Professor in Health Policy and Director of the Hopkins Center for Health Disparities Solution. And I think he was also the very first African-American professor to move through the ranks from assistant to full to chair professor. Is that correct? So, as always, Tom is and was and will continue to be a trailblazer throughout his career. Tom is world-renowned with regards to his expertise on issues related to health disparities in the United States. His research and writing has focused on three broad thematic research questions. First, what are the social and behavioral factors that predict the timing of various related health outcomes, for example, access and utilization of health services, mortality, entrance into nursing homes. Second, what are the social and behavioral factors that explain race differences in health outcomes? And third, what has been the impact of social policy on the health and quality of life of African Americans? Tom has been extremely prolific in terms of his publishing throughout his career. He's published well over 100 articles and books, as well as numerous funded grants. He's received numerous honors and awards, not the least of which being elected membership to the National Academies of Sciences, in particular the National Academy of Medicine. Needless to say, he's a very sought-after lecturer. He's held he has led seminal research throughout his career on the impact of socioeconomic and racial inequalities, the health of individuals and communities. Tom is also one of our own. He received his PhD here at the University of Michigan in 1988 in sociology, and then spent 2 years pretty much in this building on a postdoctoral fellowship working with Woody Neighbors and others. He is my friend, a longtime friend. We, Truth in Advertising, we were graduate students together back in the olden days. But Tom has prospered even beyond that which I had expected and hoped that he would do. So without any further ado, it is my great pleasure to call to the podium my friend, Dr. Thomas A. LaVeist.
Thank you. Thank you, Robert. Thank you for the graduate school together. This lectureship is particularly meaningful to me. When I was a student
Nancy Cantor, I think, was for a period of time on the faculty. I didn't know her well, but certainly knew of her work. And also, the title of my talk is about my journey to try to understand why disparities exist and what we can do about it. And that journey began in this building, literally. So another reason why this is a particularly meaningful opportunity for me. So we're talking about disparities today. At this point, there's probably no one here who can imagine this society without health disparities. Can you imagine that? What would have to happen for us to get there? What would need to change? It's now become so well known in our field that pretty much most of us can't even fathom what that would look like, but I can, because there was a time that I didn't know disparities existed. This was when I was a graduate student here at Michigan, and some of you who've written dissertations will be able to relate to this story. You know, when you are writing your dissertation and the tedium, the isolation, and boredom gets so bad that you think you're about to lose your mind. I see a few heads nodding, yeah. Well, I was having one of those days. I decided I would go out and take a walk. So I take a walk. I'm walking along downtown Ann Arbor, Michigan. So it wasn't a very long walk, obviously. And I see a bookstore, a used bookstore, and I say, well, let me stop over at the bookstore and see if I can find something to do, you know, an honorable way to procrastinate. I'll read a book, right? So I go into this bookstore, and I'm looking for something to read, anything that doesn't have a bibliography in it, right? And I come across a shelf on the used book section, the clearance section of the used bookstore, right? Now, I was a graduate student, so that was what I could afford, right? And I come across this book, A Night to Remember. Now, this is a book about the Titanic, which probably tells you something even more about my mental state at that moment, that I'd be attracted to this book, right? So now, this was a few years, probably like 10 years or so, before the theatrical film about the Titanic, right? So I hadn't seen the film yet. I've seen it now, so I know the story. So I'm thinking, you know, this is interesting, right? The book about the Titanic. I start thumbing through this book, and I come to this page where they're talking about survivors on the Titanic. And I was like, well, this is interesting. There were survivors on the Titanic. Who knew? Yeah, I didn't know. I thought ship hits, iceberg sinks, everyone dies, right? I thought that was the narrative of the story. And I was like, how could they write a whole book about that, right? But on this page, they're talking about who survived as a function of the class of ticket that they had. And I'm like, well, this is even more interesting. So I look at the data and I start calculating the death rates. So now vision this. I'm in the clearance section of the used bookstore calculating death rates. You know, clearly I was going to be a researcher. I was done. There was no turning back at that point. And here are the rates I calculated. The class of ticket was a predictor of who survived. Now we know the whole ship went down. All 3 cabins went down. Why would it matter which cabin you were in? So yes, I have seen the movie. I know exactly how it happened. But this seemed like a fascinating allusion to the US healthcare system. Big, expensive ship, handing out unequal treatment, destined to hit an iceberg and sink. And when that happens, the results are going to look something like this. Now, what happened? Why did it happen? It happens because there was only enough lifeboat space to accommodate 53% of the men, women, and children on board. So on the night of April 15th, 1911, at 11:40 p.m. in the North Atlantic, space on a lifeboat was a scarce resource. And when it comes to scarce resources, who you are determines who gets access to those resources. Okay, now this is 100 years ago, right? So you might say, well, we're much more enlightened now as a society. This could never happen today, right? Well, this picture was not photoshopped except to write in first class and coach class. This is the US airliner that landed on the Hudson River a few years ago. And if you notice, the first class passengers are on a lifeboat, the coach class passengers are standing on the wing. So, well, first of all, about that return ticket back, could we maybe consider an upgrade? No. So how is this picture possible? There is a series of policy decisions and indecisions that make this photograph possible. So most people that I encounter think that, well, if you want to change policy, you go to the legislature, state legislature, or you go to the Congress, or you go to city council, and you pass a law, and we've passed the law, and now we've changed things, and we fixed the problem. Now, in reality, that is not at all how it works. Because after you've passed the law, you then have to write the regulations and the rules that implement the law, and of course, that's where we need to be active as keepers of the public's health. We need to be sophisticated enough to understand where policy happens. But certainly, Congress could have passed a law that said it is illegal to operate an airliner in US airspace. That is certainly one way we could fix this problem. But it's not the only way, and it's not even the simplest way. The Department of Transportation could say, as a matter of their regulatory authority, you cannot operate an airliner in the US airspace without enough lifeboat space to accommodate everyone, or life raft space to accommodate everyone. But there's more. US Air could have said, as a matter of their own policy, we will not lease or purchase an airliner without enough space to accommodate everyone on the life raft. Would require Congress to do nothing for them to do that. And of course, the manufacturer of this airliner could have said, we will not manufacture an airliner that doesn't have enough lifeboat space to accommodate everyone on board. So my point is that we need to be, as advocates for the public's health, we need to be sophisticated enough to understand that policy happens in many different places. And sometimes the most impactful policy does not happen in government. It happens in corporate boardrooms also. Okay, I'll get off my health policy soapbox. Okay. So why do we have health disparities? When I talk to people, no offense, but I tend not to socialize with academics, nothing personal to my academic friends. I try not to talk about my work because I think I'm going to bore people. Maybe I will, I don't know. But sometimes people ask me, what do you do? And I have a number of little clever dodges, or at least I think they're clever, dodges where I can change the topic and get back to talking about football or whatever it is that I want to talk about. But sometimes they persist and keep asking, what do you do? Well, what does that mean? What exactly? And whenever I finally tell them, they start giving me their explanations for why disparities exist. And usually it comes down to one of three things. There's some biological or genetic difference between race groups that produces the disparities. Or it's not really race, it's socioeconomic status, which is fascinating to me because even if that were true, why would that even be relevant, right? It's the same. The problem is still the same problem. That doesn't really help us to understand anything about it. Or they say, it's really about access to healthcare. If we can just equalize this access to healthcare, we solve the problem and it goes away. We just need more black doctors, okay? So I want to go through, and it's possible that when I ask you to imagine this society without health disparities, that some of these explanations, these thoughts may have come into your mind. So I want to talk about each of these a bit, and then I want to kind of talk to you about where the research has led us, I think, to understand where the disparities are being generated and how we might intervene as a result of that. So the first one I want to talk about is the health equity issue, healthcare issue. So in the United States, I ask students often, does the United States have the best healthcare system in the world? Well, let me ask you guys, does the United States have the best healthcare system in the world? Who says yes? Okay, who says no? Okay, how many are afraid to answer? Right, there you go. That's the right answer because it's a trick question. Because the United States does have the best healthcare system in the world, and it also has one of the worst healthcare systems in the world. It just depends on which system you have access to. Because we don't have a system, we have many systems, including universal access systems. What do I mean by that? You'll see in a moment. So This is a study that was done by some guy named LaVeist a few years ago, where we looked at 3 hospitals in the Baltimore area. And I guess it's, in fairness to Johns Hopkins, I will say Hopkins was not one of the hospitals in this study, although I am pretty certain if it had been, the results would be exactly what we got here as well. But here we're looking at a procedure called coronary angiography, which is an invasive procedure to diagnose heart disease. These are patients that showed up at one of these 3 hospitals in Baltimore. 10,000 patients. We abstracted their medical records. We did an analysis to determine whether or not they should have been referred for this procedure. Every patient in this study was insured. So we took out the uninsured patients. We took out patients who had insurance that would not pay for the procedure. So everyone here had the ability to pay. Everyone here showed up at the hospital and got seen and got a diagnosis in their record that would have suggested that they were at least potentially a candidate for the procedure. Both bars on this chart should be at 100%. But there are 2 things here. First, we have an overall quality problem because the white bar is not 100% either, and that bar should be at 100%. But we have a disparity problem because the black bar should be at 100%, and it is about at 50%. It is significantly lower than the white bar. Here we have universal access to care, people being seen at one of 3 hospitals, the same 3 hospitals in the same city, all who had the ability to pay. Access to care did not address the disparities problem. Here's another example. This is from the VA hospital in Pittsburgh, and I like this study because it's one hospital. They're all VA patients, which is another one of our universal access programs or systems in the United States. They're all VA patients. They're all being seen by VA doctors at the same facility. These doctors are all paid on salary, so presumably there's no economic incentive to either treat or not treat, although there may be pressures to not treat because of costs. But here, these are patients who've gone through angiography and should be potentially referred for revascularization. 100% of these patients should have been referred for revascularization, but only about 50% of the white patients were referred and about 25% of the black patients were referred. So here we have 2 universal access systems in the United States, both producing dramatic disparities. Universal access to care will not resolve the problem. The next reason that I hear, which is not accurate, is that there are biological or genetic differences between race groups, right? So there's some gene or gene variant, right, that causes heart disease and cancer and stroke and diabetes and schizophrenia and homicide and HIV, and it makes you able to play basketball and dance or whatever, and it determines your race and whatever other stereotype you may have about race, right? Now, obviously, that's not the way that people think about it. But this type of thinking creeps into our thought patterns in much more subtle ways. And here's an example. How many of you are familiar with this drug, Bidil? Anyone? Just a handful. Okay. So I'm going to tell the story of Bidil, and for those of you that know the story, forgive me for the Reader's Digest shortened version of the story that I'm going to have to tell because of time. But basically, Bidil is a drug to treat to prevent congestive heart failure. Right? This is a debilitating disease, about 500,000 new cases per year, about 5-year prognosis after diagnosis, and it's very expensive because patients show up in the emergency department and use a lot of care in those last 5 years of life. It's a terrible condition. Right? So now, back in the 1970s, new classes of drugs were coming out, drugs that are now commonplace, calcium channel blockers, beta blockers, were coming out in the 70s. And some physicians discovered that if you combine these beta blockers with 2 very inexpensive generic drugs, these 2 drugs, that they were having a really good outcome with their patients. And they said, okay, let's do a clinical trial and let's see if we can actually prove that this new combination therapy is as effective as we think it is. So they do the trial and they find that this combination therapy is wildly effective. They published the article in New England Journal of Medicine, and we now have this new, effective therapy to address this very inexpensive and debilitating disease. And this would have been a wonderful story if the story ended there, but it didn't. They then said, well, what would happen if we put these two inexpensive generics together into one pill and then sold that? We would get an economic windfall, right? So they go to FDA and they say, okay, we want to come to market with this new drug. And FDA says, no, you can't come to market with this new drug because that trial that you published in the New England Journal of Medicine was fine, but it wasn't done exactly to our standards, so we need you to do a new trial. So if they do a new trial, of course, by the time they complete that trial, the drug would be off patent and they would lose the economic windfall. So what do you do? Well, you do what any red-blooded American researcher would do. You go back and you do a little data mining. So they go back to the original data and they do a little data mining and they discover that this combination therapy is more effective in Black patients. Now, I said it that way intentionally. Have you heard that terminology before? This drug is more effective in Black patients, this drug is more effective than white patients, and so on and so forth. What does that mean when we say that? Here's what that means. Let's say that we have 200 patients, 100 white, 100 Black. We're going to keep it simple. 100 Black, 100 white patients. They have the same condition, and we have a drug that we think will be effective with this condition. Now, I'm going to stop here and tell you that this is not a trick question that I'm going to ask you. I'm not trying to trick you. This is a real question, okay? But I know you're not going to believe me anyway. So, okay, we give the 200 patients the drug. And here are our results. 75% of the Black patients benefited from the drug. 65% of the white patients benefit from the drug. Now, in the real world, if we had numbers like that, that would be unbelievable. But okay, this is my made-up fictitious story, so I get to say 75 and 65. So now I can assure you that that 10 percentage point difference would most certainly be statistically significant. Okay, you following me? Are you out there? Okay, hold on. When I call, you do what? Respond, right? So you do know what you're supposed to do, right? I call, you respond. Okay. Now, the results, 75% of Black patients benefit, 65% of white patients benefit, 10 percentage point difference, sample size of 200, that is going to be significant. You don't have to look it up, I can assure you it will. Have we found a Black drug? Is the drug more effective in Black patients? Who says yes? Okay, who says no? Who's afraid to answer? Who's afraid to even answer that question? Most of you, right? It's not a trick question. Okay, the answer. No, the drug is not more effective in Black patients. If you were part of the 75% of Black patients that benefited, you benefited. If you are part of the 65% of white patients that benefited, you benefited. You didn't benefit more or less because you're Black. It either worked for you or it didn't work for you. We have not found the Black drug that will solve the health disparities problem and make it go away. We have found the drug that is effective in a larger percentage of Black patients. That would be an accurate statement. But we haven't found the drug that should only be approved for use in Black patients. Okay, now, when they went back and did their data mining, their results were something like what I just told you. And then they went back to FDA and said, well, we've got a new patent, this time for use in only Black patients. And then they did a clinical trial on only Black patients. And what do you think they found in that clinical trial? You guys really are afraid, huh? Well, they found that it was effective. Why? Because Bidil is effective, and it didn't matter if it was a Black sample or an Eskimo sample or any other sample. Everything we know about Bidil is that it is an effective drug. So they go back to the FDA and say, now we want to come to market with this new drug for use in only black patients. And in 2005, not 1905, 2005, 2 years after the Human Genome Project demonstrated that there is no difference at the genomic level between race groups, we get the first drug approved for only one race group, African Americans. So, to whom do you prescribe Bidil? Do we prescribe Bidil to this African American gentleman who has one grandparent from Ireland, one grandparent from Scotland, two grandparents from Jamaica, and is born in the Bronx? This is Colin Powell. Do we prescribe Bidil to this African American gentleman who has two white American grandparents and two Kenyan grandparents? And Kenya is, of course, from East Africa, which is not where most African Americans' ancestry is from, which is from West Africa. This is President Obama. Do we prescribe Bidil to this African American gentleman? Okay, now this guy's got one Chinese grandparent, one Thai grandparent who also has Chinese ancestry. He's got a white American grandparent who also has Native American ancestry. He's got a black American grandparent who also has Native American ancestry. From whom did he inherit his Bidil receptor? And how do we know when all we have to go on is what he tells us when we ask him what is his race? Because if you ask him, he will tell you that he is Caucasian, which is a word he made up to try to capture all of the ethnicities that capture his background, which is literally an accurate description of what he is. Caucasian. That's another conversation I would like to for another time. Do we offer Bidil to this guy? Looks like a black guy to me, looks like a guy I know from Cleveland. And of course, this is Vijay Singh, who is not an African American at all. And hopefully Vijay will never, he's from Fiji, by the way. And hopefully Vijay will never need Bidil. But if ever he did, I would hope that it would be made available to him. So when science and politics and policy come together, inevitably the loser is science. So to quickly give you the end of the Bidil story, the reason most of you have never heard of Bidil, even though we know it's an effective drug, at least everything we know about it tells us that it is that, so they came to market in 2005 with Bidil, and no hospital would put it on their formulary, and everyone said, well, why would I prescribe this expensive combined drug when I can just prescribe these two really inexpensive generics? That's what everyone did. And then eventually Nitromed, the company that licensed it, was delisted from the New York Stock Exchange. Now a private equity firm has purchased the license, and they're marketing very heavily, especially to black physicians, this black drug. That's the Bidil story. So this is the folly of the idea that race is biological. Race is determined by the rules of the society and how that society goes about deciding who gets categorized into which group. And of course, the groups are categorical, but human variation is not categorical. There are many people who comfortably fit into the categories, and there are many people that do not comfortably fit into the categories, because the idea of categorizing humans into these groups, you're trying to categorize human variation, which is continuous, and put it into categories. There's the problem with it. So finally, it's not really race, it's socioeconomic status. This one is easy. I'm going to quickly go through this one. These are some charts that I put together just demonstrating that regardless of level of education or income, we still find disparities. It doesn't really matter much what the outcome is. These are just a couple of examples. This thing is not moving for me anymore. Okay. The pattern is the same. Here are some examples using income Note that here we have incomes over $175,000, so even at the very highest income levels, we still find the disparities existing. And this is an interesting one here, because unlike the pattern with other conditions for hypertension, African Americans, when you get into the highest income categories, risk of hypertension actually increases. This is the chart from a paper that we're working on that we'll be submitting soon. And we can talk about that a little later if you'd like to discuss that. So now, when I show those charts, there's usually some aficionado, some fellow data nerd in the room who says, oh, well, we deal with this issue because we have multivariate modeling. So I'm going to give a brief message to my fellow data nerds about why multivariate modeling does not resolve this problem. So I'm going to do a quick demonstration. And it's particularly fitting that I do that here at this school because this is where I learned the math to do this, so the statistics to do this. So you'll tell me if I'm right. So I'm going to use the National Health Interview Survey. I'm going to try to keep this simple. We're going to look at all adults, 33,000 people, over age of 40. And we're going to look at three variables: income, race, and ADL. ADL, activities of daily living. This is a measure of physical functioning. Okay? There are 4,400 African Americans in the sample, and these are the sample sizes within each income group. Okay? Dependent variable is ADL, right? Now, we're only going to look at whether they have one ADL limitation, which is a very low standard. Can someone verify for me that it is a very low standard? One disability. Is anyone out there? I know it's Friday afternoon. You're trying to get to the weekend. I will speak as quickly as I can to get you there. Okay. So we're going to do a simple analysis of can we do a study of race differences in ADL, one ADL limitation, controlling for income. Okay? So what do we do? Now this is Biostats 101. First, we look at the bivariate relationship between race and ADL. And here we have done logistic regression, and we get an odds ratio of 1.46. The confidence interval tells us that this is significant. So far, this is telling us that African Americans have 46% greater odds of having an ADL limitation compared to whites. Am I right? Okay, so I've passed 101. Okay, good. Then we're going to look at income. As income increases, the odds of having an ADL limitation decreases. Confidence interval tells us that that is significant, right? So far, everything is as we expect. Now, Biostat 102, we do what? We put race and income together and we see what happens. So first, let's look at income. The pattern is the same. As income increases, the odds decrease, and confidence interval says it's significant. But what happens to race? The race effect is not significant, right? So what do we do now? What's the next thing we do? I'll turn to the provost here. What do we do? Oh, no, we got Chairwoman Howard here. What do we do next? We got these results. You published the paper. Who are these people? You published the paper. You published the paper, okay. And then your chair. What is that? Well, this is a dramatically underspecified model, but this is intentional because I'm trying to demonstrate something. All right, so assume there were other controls. All right, so you publish the article, and then when it's time for your annual review with your chair, you tell the chair that you published. I'm a department chair, so I get it, and I get happy. And then when I'm determining their merit raises, I'm going, oh, he published that article, or she published that article, right? And that's all is right with the world, except you have now added false information to the research literature. Because if you had done this, array the data by race and income and looked within each cell, you would discover a couple of interesting things. First, in the lowest income category, there is in fact a small, possibly not important, but statistically significant difference in ADL limitation. But more importantly, you would discover that for the category of African Americans with incomes over $75,000, that rate is only being calculated on the basis of 8 events. So there are only 8 African Americans in the, now this is the National Health Interview Survey, the official record of the health of the US population, the most official of official data sets there are. All right, this is not some made up data set. Second of all, remember the sample size. Now, Dr. Howard suggested that we needed more variables in the model. If we had more variables in the model, that means that the cells would get even smaller and that we'd be calculating even rates on an even smaller number of events. Now, I know a lot of statistical trickery to get data to confess all sorts of things, but I don't know a trick that makes me comfortable calculating a rate on the basis of 8 events and then extrapolating that rate to the entire country. Now, before I go any further, I'm going to say if you go to PubMed and you punch my name up, you will find that I have committed some of the same sins that I'm here talking to you about today. So the point is not he who is without sin can cast the first stone, but rather it's that we should repent, go forward, and sin no more. Okay. These are not the weighted data. So you've added another level of complexity. If we had used the weighted data, it would be even worse, right? Because it weights down African Americans and weights up whites. I know some of you are getting worried, right? Don't worry. Another problem. So this is a high school in the Baltimore metropolitan area. I'm taking this picture at the entrance to the campus. As you can see, you can't see the buildings from the street, but there are trees and a lawn. As I drive onto the campus, you see more lawn, and here are some of the buildings where the classes are held. I come around to the side of the campus, and here's the gymnasium at this high school in the Baltimore area. Here's another high school. This one is an upper middle class suburban high school. I'm at the entrance of the campus again. There is a lawn and some trees, but the building is clearly visible to the street. I come around to the back of the building, and here's the soccer team going out for afternoon practice on an open field. And when I come around to the side of the building, here are the portable classrooms, because in this upper middle class suburb of Baltimore, the building is not sufficient to accommodate all the students. So finally, here's a high school in the Baltimore metropolitan area. So there's no lawn, but if you look closely, there are some weeds here in the cracks, and there is a tree. So what is my point? My point is that the graduates of each of these institutions are coded in your data set as high school graduate. Do you think that there are possibly differences in the life chances and opportunities of the students that go to these schools? I'll give you one guess. I bet you get it right. Do you think that there are differences in the racial distribution of the students at these schools? So do you think that when you take your national data set, National Health Interview Survey or whichever, and you plug in education as one of your independent variables, that you have now adjusted for differences between race groups? Again, don't despair. I've committed the sins also. The point is, sin no more, or at least sin with caution and knowledge. Okay, so if it's not genetics, healthcare, or socioeconomic status, then what is it all about? The United States is a dramatically racially segregated society. People live in the country together, but we experience the country in very different ways based on our race groups, our socioeconomic status groups, our geography. This is a map that was produced at the University of Virginia based on the 2010 census. Now what they did here was they placed a dot on the map representing every American, like 320 million dots. How long did it take to do that? And they color-coded these dots. The blue dots are white Americans, the green dots are black Americans, Asians are orange, are red, and orange is Hispanic. So let me come in on a city here. This is Detroit. The pattern here shows This is 8 Mile here. And so other than Southfield, very few African Americans living above 8 Mile. Here's Ann Arbor. Again, the greens are a little more interspersed, but there are clearly pockets of greens, but not fully interspersed throughout the city. This is the Ipsy area here where you see a larger pattern of green. Here's another city. Okay. Isn't it? Okay. New York City. New York City, just to orient you, this is Manhattan Island here, and this big rectangle is Central Park, because no one lives in Central Park, right? But before coming to graduate school, I was a social worker in New York, working with homeless people in Manhattan, and I can assure you there were people living in Central Park because I personally knew some of these people that lived in Central Park. It was my job to know them. And this is Brooklyn. I've circled Brooklyn because people from Brooklyn believe Brooklyn is the center of the universe. And of course, they would be right. It is the center of the universe. This mass of green here in central Brooklyn is where I grew up. A community called Brownsville, 86,000 people living in a 1.5 square mile. How do you get 86,000 people into 1.5 square mile? You do that by having them live on top of each other. And here is the, this thing is not working. Please excuse me 1 second. Here's the building where I grew up and the elementary school that I was supposed to go to but didn't go to because they condemned the school just before I got there. When I say condemned the school, they just put a padlock on the door and they walked away and left the building to rot for the last 40 years. And if you look closely, you can see the foliage growing out the top of the building. It's grown over the last 40 years. And so I went there this winter to try to get a picture of that, but unfortunately, it didn't occur to me that there would be no foliage on the branches in the winter. But if you look closely, you can see the branches. So here are a few more pictures I took while I was there about the food environment in Brownsville. There are communities like Brownsville all over this country. And here's some kids. I took their picture because if it had been 40 years ago, I would have probably been one of those kids. But if you look above their head, we see Crown's Fried Chicken, which is ubiquitous in East Coast cities. The food environment in communities like Brownsville, communities that exist all around this country. Here's some pictures from my adopted home of Baltimore. These are corner stores. They sell pretty much malt liquor, cigarettes, lottery tickets, some foodstuffs, wine, cheap wine. This one is a few blocks away from where my office was when I was at Johns Hopkins. And this is my favorite one. This is L&M Liquor. I really respect the truth in advertising here. So as I'm taking this picture, this is the perfect public health moment. When I'm taking this picture, I'm standing in the parking lot of a funeral home that's owned by a friend of mine. And there's a funeral of a 22-year-old black male who had just had a heart attack. 22, MI, death, right? And I'm standing in, this is like the perfect public health disparities moment. And I'm taking a picture of this store directly across the street. And what I respect about this is the truth in advertising. L&M Liquors, they sell beer, wine, and medicine. And of course, the medicine that they sell is the medicine for the ills, the elixir for the ills of poverty, malt liquor. So I'm sure I'm the only one here that knows what malt liquor is. Oh, because I'm the only person that went to college in this room, right? I'm the only one. Anyway, malt liquor is not beer. Malt liquor has about double the alcohol content of most commercial beers. This is part of my collection of malt liquors. I literally have a collection of malt liquors in my office. Notice that they're all still, the caps are still on them. Some have been like that for decades. I don't know what would happen if we opened them. Malt liquor is also sold in much larger denominations. So here I have the quintessential 12-ounce beer, just to juxtapose that size to the 40-ounce malt liquor. Boxer is one of the local Baltimore malt liquor. Green Lightning is from Brooklyn. And then of course we have Old English 64-ounce bottle of glass. How heavy would that be? But it is an engineering marvel, genius. It is ergonomically designed for easy one-hand consumption. It is a thing of beauty. It is an engineering marvel. It is evil genius, but it is genius. Right? So we got an idea. It's always been said that these stores and these products are sold disproportionately or almost exclusively in Black communities. And we said, well, can we do some research to actually document that that's the case? So we were able to get the location of these stores by getting the liquor licenses from Baltimore and placing them in their census tracts, and did a study where we located them looking at the income and racial distribution of the communities. When we refer to segregated Black communities, we're talking about a census tract that is at least 90% Black. That's what segregation, that's how we defined it here. And we see that these stores are almost exclusively located in low-income, segregated Black communities. This is how it is that segregation produces differential risk environments. And these risk environments track with race. And when we look at national data, and we don't account for the fact that we live in the same country, but we don't experience the country the same, we don't account for the differential risk environments that we live in. It would be like if you turn on Good Morning America in the morning to find out the weather. And they said, the national temperature today will be 42 degrees. Now that is a statistic that can be calculated. But is that a valuable statistic? Can we make decisions based on that number? Does it tell us here in Ann Arbor if we need a coat today? Or in San Diego, if they need one? This is what we rely on in our decision making. Data that tries to encapsulate 11 time zones from Maine to Hawaii, and yes, Hawaii is part of the United States, in case you didn't know that. So, how does segregation affect health disparities? So, I'm going to tell a couple of really quick stories that demonstrate how this happens and why a lot of what we think we know, we may not actually know. So, this is a story about a paper that I was asked to review for a really fancy journal. I won't say the name of the journal because I don't want to out the author, because the author might be in the room. It was blind review. I do not know who the author is. You're not going to want to claim this one. So if it is your article, simply remain silent and don't out yourself, right? Nobody's got to get hurt, okay? So this fancy journal, which will remain nameless, it was a fancy journal from New England, and it was a medical journal, but I won't say the name. And this was in the days where they still did things in paper. I see a few of us here remember those days where they would actually mail the manuscript to you. So I go through this manuscript, and I'm reading it, and the title is something like Race Differences in Firearm Use Among Adolescent Males. You know, you've seen those types of titles, right? So I'm going through this article, and unfortunately for the author or authors of this article, the data was from Maryland. And unfortunately, that journal in New England had sent it to someone that lives in Maryland to review it. So as I'm reading this, I know all of these communities that they're mentioning where they got their data from. I know all these places. And what I determined is that the Black males are from Baltimore, and mostly East Baltimore, which I know because that's where my office is literally located. The white males are from Garrett and Allegheny County, Maryland, which is in the Appalachian region, mountain region of Western Maryland, which I also know because I vacation there. So I know both of these communities. The whites are from Allegheny and Garrett County, the Black males are from East Baltimore, right? The white males are shooting long guns or rifles. The Black males are shooting handguns. The white males are shooting at wildebeests or whatever. No, I know there are no wildebeests in Western Maryland, I know that. But there are bear there and lots of deer. And the black males are shooting at each other, right? Now, I know a lot of statistical trickery to torture data, but I don't know one that makes this a race comparison. It's a comparison of urban versus rural, maybe. It's a comparison of one type of hunting culture versus another type of hunting culture. But what would it need to be for this to be a race comparison? You have to have black males from Garrett and Allegheny County, of which there are some because I have personally seen them with my own eyes. And you'd have to have white males from East Baltimore, of which there are some because I have personally seen them with my own eyes. Now, this is an extreme example that illustrates much of the fallacy that is pervasive in the health disparities literature. That's an extreme example. Now, here's a more subtle example of how it happens. So a colleague of mine comes over, and I'm going to be as careful as I can with this one because this is I believe, well-meaning, good person who wanted to do good. Colleague from the medical school, so it wasn't public health, we can at least say that, medical school. Sorry if I'm offending any medical school faculty here, but it was medical school. John, I'm sorry, it's one of your people. Anyway, colleague of mine, good guy, asked me to review an article that he just wrote on data that he collected at the hospital. And so I agreed to do this before he submits it to the journal. So I reviewed this manuscript for him. And what I note is that most of the white patients came through the ambulatory care center, the outpatient center. Most of the black patients came into the study through the emergency department. Okay. And you're looking at differences in outcomes of a condition, which I will not name because it's not relevant. So the black patients did not do as well as the white patients. But we know that patients coming through the outpatient center are more likely to have come with an appointment. They were referred by a physician in the community that has admitting privileges at the hospital, that there's going to be, when they're finished, once they get discharged, they're going to be released back to that physician, so there'll be some continuity of care, and the expectation is that they would have a better outcome. The patients coming through the emergency department are more likely to be coming in crisis, so they're already in a more severe state when they get to the hospital, and then they get admitted to the hospital. They may or may not have a physician in the community that's following them at all, and if they do, it's a good chance that that physician does not have privileges at the hospital, so the continuity of care we know and we expect is not going to be as good. So I go back and I say, I don't know, I wouldn't publish this article if I were you because you have this design flaw in your study. You need to go out and collect more data. You need to get some white patients that came through the emergency department. You need to get some black patients that came through the outpatient center. And you need to equalize that a little more. I wouldn't submit the article. This individual thanked me profusely for my input, submitted the article, and today that article is published in a really fancy, well-known journal that's not published in New England, but it is a well-known journal. This is the more subtle and insidious way that the segregation, the different experiences that we have in this country permeates the health disparities literature and may, in fact, lead us astray in our understanding of why these disparities exist. So what do we need to do to equalize things so that we can make true comparisons among race groups that are actually comparable? We can't, I submit to you, we cannot do it with data analysis, which is the way we typically try to do it. I submit to you that it can only be done by dealing with this problem at the design stage of the study. We need to find communities that are racially integrated, naturally occurring communities where people are living in the same community, not similar communities, but the same environment with the same exposures to its social determinants, the social factors, and where at the individual level, their socioeconomic status is equal enough that we can say that socioeconomic status and social factors are a constant, not a variable that we have to try to figure out how to measure and then how to model. So we got this idea. What if we can find communities around this country that were racially integrated, that did not have substantial differences in income and education levels? And we went through an exhaustive search of census tracts in this country. 168,000 census tracts in the United States. How many tracts do you imagine met the criteria of having at least 35% black and 35% white people living together in the same census tract with no significant differences in income or education? How many? Two? God, you're even more jaded than I am. I like you, that's good. But it's wrong, it was more than 2. 10? You're jaded too, it was more than 10. 150. The answer is 425. 425. I said 425 out of 168,000. Okay, so I haven't even calculated what that percentage is. It's small. So we identified these communities that met this criteria. 35% black and 35% white living together. Median income and high school graduation rates were also very similar. And fortunately, we found 2 census tracts that were contiguous and were located in Baltimore. And we said, okay, we're gonna go there. And we're gonna replicate the protocol from the National Health Interview Survey and NHANES and say, do we find the same disparities that we find in the national studies, okay? That's what the study is about. So just a quick profile of the community. These 2 census tracts, 51% black and 44% white. Median income is very low, but as you can see, equal. This is from the census. Poverty rates were high for the time, but also very, very much equal between both groups. Distribution of educational status also very equal. This is about as close to laboratory conditions as you're going to find in a naturally occurring environment, where we can make the social factors a constant and not have to try to make it a variable. So we went into these 2 census tracts, did a 40-minute interview. They were done, almost all of them were done in their homes. And we were able to successfully interview 42% of the adults living in these 2 census tracts over a 12-week period. And if you want to know how we did that, I'll tell you about that a little later. So how well did we represent the community? So the blue represents the census and orange is what we found. I think we did a pretty good job of representing the community in terms of here's income, educational status. We've got a few here, we're a little overrepresented and underrepresented there, so we'll have to adjust for that in the analysis, and distribution by sex. So what we did is we go into the literature and we identify a paper published in a peer-reviewed journal using a national data set, either Health Interview Survey, NHANES, or MEPS. And we replicated the analysis that they did in that paper, and we replicated that analysis in that data set, and then we did the same analysis again in our data set, right? And remember, we used the same protocol. So we used their questionnaires, we asked the questions the same way, we collected the data exactly as they did. And so here's just an example. This is for hypertension, and these different models, just model 1 through 4, just represent 4 different papers that we pulled out of the research literature. They have different controls, different variables that they're adjusting for. So we replicated those models. And if you look here in all in the NHANES, you see that consistently the odds ratio is 2. So African Americans have double the odds of whites of being hypertensive. So this is what we teach in our classes. This is what we tell everyone. And we tell clinicians that African Americans are supposed to have higher rates of hypertension because that's the way it is. They're double the rate. And then we even have theories about genetic differences that cause that. In our community, where people are living under similar social conditions, we do still find significant differences. As you see, the odds ratios are significant for each one. The confidence intervals show us that. But the odds ratios are substantially smaller in each case. ranging from 29 to 34% smaller, would say that at least some portion of the disparity is the result of social factors. So that's for hypertension. And here's just a summary of a couple of the other papers that we've done using other conditions. For diabetes, in the national study, we see the rate of diabetes, about 61% greater odds for African Americans to be diabetic compared to whites. When they're living in the same conditions, we find no significant race difference in diabetes. For obesity, this is obesity among women, 87 times greater odds that black women will be obese compared to white women. In the sample where people are living under similar conditions, we find no significant race difference in obesity. The hypertension results I've already shared with you. And this is use of preventive health services. I just thought this was interesting that in either case, this is a non-significant finding, but it was illustrative, I thought, that the directionality of the relationship did reverse. So, I submit to you that there are, in understanding disparities, 4 great disparities that we have to account for, and that we will not solve the health disparities problem until we realize that it is part of a comprehensive set of disparities that are being addressed in other parts of this campus. And these 4 disparities are health disparities, educational attainment disparities, wealth disparities, and disparities in criminal justice. And by that, I'm talking about aggressive policing and mass incarceration, both. And each of these disparities cause each other and are caused by each other. One of the best documented relationships we have is between education and health, and we also know that children that are not healthy are less able to develop educationally. We also know that people wind up in prison. People in prison populations have very high rates of illiteracy, and it's difficult to get an education when you're in prison. People wind up in jail, in prison, because they're not able to afford high quality legal services. And the best way that I can think of to ensure that people will not create wealth is for them to be in prison between the ages of 17 and 34, which is the period of time where most of us develop the human capital necessary to create wealth. The health and wealth relationship is well known, and we know that people wind up in prison because of undiagnosed and untreated mental health conditions, and that people come out of prison often sicker than they were when they went in. So none of these relationships should be a surprise to anyone in this room. But rarely do we realize that our disparity, the health disparity, is being caused by and is causing the disparities that the people are dealing with, wealth disparities, or educational disparities, or criminal justice disparities. And until we start working with people across sectors and realize that this is a broader societal set of causal relationships, our disparity, health disparity, will never be solved, and neither will the disparities that are being addressed by these other groups. So I want to end on one last thing, one last point that I want to make. How many of you here are aware that there are more black men in prison than in college? Okay. How many are afraid to raise their hand? Okay. So I've been a black male in this country for 56 years. And, I'd heard that statement made many times, but it just did not jive with my personal experience. And as I pointed out to you earlier, I grew up in one of the toughest neighborhoods in this country. And that didn't make sense to even me, that there would be more black men in prison than in college. So I actually went to the US Department of Education and Department of Justice and pulled their data to see if that statement was true, because it just didn't seem right to me. So this is what I found. In 2006, there were 86,386, there were over 800,000 black men in prison. There were nearly 900,000 black men in college. Now, the college age population tends to be about 18 to 23, 24. Prison adult population can be any age, right? So what if we can limit that to just a smaller range? So the data systems would only support 10-year ranges, so I picked 20 to 29. So that year, 310,000 black men in prison, 480,000 black men in college. Again, more black men in college, which jives with my personal experience, and at least that made sense to me. Then I said, okay, maybe it used to be true. So I went back as far as their data systems would allow to see if it was ever true that there were more black men in prison than in college. And what I found was that there was never a year where that statement was true. There are more black men in college than in prison. Now let me say a couple of things. This is both jail and prison. This is state and federal prison. And this is only 4-year college. I did not include graduate school. I did not include associate's degrees because I didn't want people to say, oh, well, he's gaming the system. And so only 4-year college. There's almost 500,000 more black men in college pursuing a bachelor's degree than there are in all federal and state prisons in the country. How is it possible that so many of us would believe that something that is so untrue is true? What does it say about black males? What does it say about black male victimization? What does it say about the expectations that we ascribe to black students, black male students in particular? What does it say about the way that we go about health education with black males? That the reputation of black males would be so bad that such a lie, such a big lie, could be believed by so many of us, including African Americans. This is the question that I'd like to ask you to ponder. So when I began this lecture, I asked you to imagine this society without racial disparities in health. I asked what would have to happen? How would we get there? What would need to be different? And when I asked that question, I'm certain that some ideas came to your mind. I ask you again, can you imagine this society getting there? Now, what do you think would have to happen? I thank you all for your attention and for coming to hear me today. Thank you. Thank you, sir.
So we have time for a few questions.
Yeah, I get that question all the time, and I wish I had an answer for that. I wish I had a good answer. I don't have a good answer for what happened. There was that period of time where the rates were very close, but it never crossed over to where it was more in prison. But I don't really know. I actually did look that up and look at the laws that have, over the years, that have led to mass incarceration, and it doesn't track with that. It doesn't appear to be the result of that. It was probably had, I'm supposing, and I don't know this to be the case, probably had more to do with rates of college attendance during those years than prison, because the prison, if you look at the prison data, it just goes straight up. There's no dip, it's just going straight up. So I didn't pull the education data, but probably it took a dip. Oh, I thought you were gonna.
Oh, I'm sorry, I will.
I'll call.
I will?
Then I'll do it. I'll call. Yes.
Thanks, wonderful presentation. I spent a little time in Singapore. We're very proud of their health system. And of course, they don't have African American, a significant African American population, but they have a lot of racial variation. And they have had quite a history of race riots.
Mm-hmm.
So forth. The government became very paternalistic and controls about 80% of the housing in the whole country. And they put in a rule, which I believe is followed pretty well, that every building that government determines who lives there, or they have to apply to the government to be able to be public. Every building has to have a representation within its population of the various ethnic groups that make up some. What if, I mean, is that, do we need a kind of give up some of our individual freedom to live where we want, to be able to have a paternalistic national system that forces everyone to share in the good and bad of all these neighborhoods.
Well, I think the solution has to be solutions that work within the culture of the country. And I think that a solution like that would not work in this country. If you look at some of the public housing experiments that was attempted, not very successfully, by the way. If we also look at some of the, this was back in the 60s, but some of the more recent attempts to move people into different communities have not been as successful either. And I just think that's difficult in a country where this idea of individual freedoms and freedom of movement is such a key tenet of the country's cultural and social DNA. So I don't think that's a solution that would work here. Also people live where they choose to live, and sometimes people choose to live in communities where they feel more comfortable because of the ethnic makeup of that community. And I'm not just talking about whites, I'm talking about blacks and Hispanics and Asians, and choose to do that even though it means that they have less access to amenities. So I think there's a combination of factors that makes that very complicated, and I don't think a solution like that would really work here. I don't know who to pick on in what order, but yeah, why don't you take that over for me? Thank you.
Thank you very much for the great presentation. I have been following your papers and your work because I think it is relevant. My work and informs my work.
It's good to know somebody's reading that stuff. Thank you. And I thank you for that.
Some of your papers have tried to or have shown that maybe STS at least partially explained the racial differences in health. Like, for example, that paper that you showed, with the exception being smoking, many other disparities go away when blacks and whites have the same SES. Some other papers, like this 2017 paper, suggest that the disparities are largest when SES is highest. So disparities do not diminish at the highest level of SES. They get worse for some reason, which becomes
for some outcomes, but yeah.
For some outcomes,
yeah.
Yes. That becomes close to what David William has argued, that SES does not mediate, but differently influence the health of different groups. And then you have some papers which say maybe it is not race, it is place. So, and now the final conceptual model that it is a combination of those factors. So after all this journey, my question is, do you think, is it outcome specific? For example, for physical health outcomes, it is partially mediation. For some mental health, it is. So can you describe the whole summary in very...
Where I think it is?
Yes. Why?
Yes, okay. I think that race determines place, and place determines health. But there's nothing endemic to race groups that produce the health outcomes. There's nothing about a person being black or Hispanic or Asian or white that determines what their blood pressure level should be. This is scientifically, the physiology of that makes no sense, although that's what we teach literally in our classes. But it makes no sense physiologically, right? So it's something happening in the social environment. The group that you are categorized in determines the set of social conditions that you live under. And it's who are living under those conditions that determines the outcome. And they're correlating with race, obviously, because race is the determinant. So when you look at the national numbers, you see those patterns. So I do think that what I would say is that it's place, it's the environment, the social as well as the physical environment, that is what is the driver. But in this country, because the way that we as a society has decided to use race, race determines who gets exposed to those environments that have the worst, that produce the worst outcomes. That's where I would come down with this. Now, what happens with high income levels? So it's really hard to study high income levels in this country because I've often said the two most understudied groups of white and black people, because Asians are the most understudied group. If you look at just the black-white thing, that mostly what we've done in this country, it's high-income blacks and low-income whites. Nobody wants to, we have this data set on low-income whites and urban low-income whites. We've had a hard time getting those papers published because nobody wants to publish articles on low-income whites to see that their health outcomes are just as bad as low-income urban blacks. They're horribly bad outcomes. You look at the opioid crisis right now, about 90 deaths a day, and it's mostly whites, low-income whites. The other group is high-income blacks. Nobody studies high-income blacks. It's really hard to get that data. So we were able to get this data set by combining like 7 years of data, and where we can get enough people to start to calculate rates. And what we're finding when we're able to finally study groups like that is that there is something, I believe, in being that high-income black, being the one black person in the room most of the time, living that is the kind of the outcome that is associated with upward social mobility. You become isolated, socially isolated, and I think that social isolation becomes a social factor that affects you. So while you are able to purchase your way out of other exposures, you then acquire additional exposures that maybe you wouldn't have if you were a lower income. So it's a different risk profile, different source of risk that's producing the outcomes, but the disparities we find actually may even widen at the highest income levels. I don't know if that was succinct enough, but that's...
Makes sense, thank you very much.
Okay.
We have time for one more question?
Thanks, Tom. Great lecture. Following up on your place concepts with your census tract research, I thought was very innovative. Could you tell us more about those communities? What's more about the lived experience of
Thank you. Yes.
Does it differ for the whites and blacks in those communities? Are the schools and churches and workplaces integrated or segregated?
Yeah, so it's a really interesting community. This is in the southwestern portion of Baltimore City. And this community has been racially integrated at least since the 1940s. So what happened is during World War II, whites from West Virginia moved to Baltimore for jobs, manufacturing jobs, which was in that sector of the city. Blacks from the South, mostly North Carolina and Virginia, moved north into Baltimore for jobs. And they wound up living in that community together where they've been since the 1940s. The community is still very much racially integrated. We also looked at the level of census block groups, and then we also looked at city blocks to look at how integrated they were. We did find more segregation within the specific blocks, but still much more racially integrated than you would in any other community that I'm aware of. And you did find both groups living in all of the sectors of those two census tracts. So it is integrated. Very low income, median income was less than $25,000. Now, the health problems in the community are not the result of fast food. There are no fast food restaurants in these two census tracts. There is no bank in these two census tracts. There is no supermarket within these two census tracts. There are no chain restaurants or chain stores except Rent-A-Center, the only national chain located in these two census tracts. What you have there in the food environment is mom and pop fish fries, pawn shops, and that's pretty much the liquor stores. That's pretty much the legal economy there. There's a thriving illegal economy there as well. And so there is a lot of crime. It's a high crime area. But that racial integration, that racial distribution has been pretty stable, at least for the last few decades in that community. This is not a story of gentrification either. This is a pretty stable, low-income, racially integrated community. In the 60s, when some people were able to move out of that neighborhood, predominantly the blacks, the higher income blacks, or better educated blacks who move out of that neighborhood, they did, and what they left behind were the low-income blacks, along with the low-income whites who couldn't get out.
Well, I'm actually going to give one more question.
Okay.
Since you asked Professor Caldwell a question, it's only fair she should get the opportunity
Certainly.
put you on the spot.
Since I called her out, okay.
That's right.
Well, she could put me on the spot more than having to remember papers and like,
No, I'm not going to do what Sherman
that was
did.
tough.
But I'm going to Thank you for the talk. I really did enjoy it. But it did make me wonder, we end up with your conclusion basically around place really matters. And when we go back to W.E.B. Du Bois, the Philadelphia study from 1905, same conclusion. So my question really is, what do we need to do in order to get change? So we don't need any more health disparity studies. We really need something dealing with what we need to get at that change, so the intervention part of it. So I'm wondering what your thinking is about moving towards that intervention.
Yeah, I know the Philadelphia Negro really well, and it even goes back before that to studies in Paris in the early 1800s that demonstrating that place matters. So, so how do we move towards solutions, what you're asking?
Yes.
I think we move towards solutions through policy. Policy is I tell my students all the time that, and through policy, we can change reality. We change the rules by which the society operates. So we need to be in positions where we can impact policy and distribute resources in a way that produces more equitable outcomes.
And by that you mean public policy, not health policy mostly, right?
I mean policy. Policy happens in many places. There is no legislature that determines that one community will be a food desert and another one will not. That's corporate policy that makes that decision. So when I say policy, I mean policy in all the places where policy happens. And it happens in many places. So we need to be everywhere. We need people who operate from a health equity lens need to be on corporate boards. We need to be in the legislature. We need to be influencing the legislature. But we also need to be influencing the rules makers, which are the bureaucrats. And we need to be in communication with them as well. So I think it's helping people to understand the complexity of how the society is organized and how that organization comes about. And it doesn't come about simply by passing laws. So I say policy writ large.
So with that, I want to thank Tom for coming out today. Please join me in thanking him for So before we end today, I just want to do a couple of things real quick. First and foremost, while I'm doing my thank yous, I want to make sure that you all join me in thanking Bill Das, Mike Moreland, and Crystal Flynn for helping to organize this year's lecture series. They've worked very hard in pulling this together. So please join me in thanking them. I want to also acknowledge Evan Dobson, as well as the larger School of Public Health, for help co-sponsoring today's event. And last but not least, I want to also, if you like this, which I'm sure you did, want to also invite you out on Monday to a series of panels and symposia in honor of James Jackson, who will be given the very first Distinguished Diversity Scholar Career Award. There'll be panels held all day on, help me out, Cleo.
Aging, religion, policy, and
Discrimination.
discrimination and identity.
All held at the at Rackham Amphitheater Monday, starting at 9 or
9 o'clock.
9 o'clock, going into 2 o'clock, and then James Jackson will be giving the inaugural lecture at, I believe, 3:30.
3:30. So the symposium is from 9 o'clock until 3, lunch included. And then 3:30 to 5, James will be giving his address.
So please come out, both in terms of nourishing your mind, your heart, as well as your stomach, and perhaps most importantly to honor someone who is deeply deserving of the award. So with that, I just want to again thank you all for coming out. Wish you a wonderful weekend. Also to let you know, I'm being told there is food outside. So particularly graduate students, if you Make sure you get as much food as you would like for today and tomorrow. Back in the day, we used to walk around with baggies, and the quality of the food determined often which of the lectures we went to. So we spent a lot of time over in Ross, not as much time over in psychology. But thank you all. Have a wonderful weekend. Oh, you know I got you.